while we're getting the slides up, Miller and the Miller community, the survey that we did has been a long history with Tetra, and it parallels with my journey with Southwest Sydney Local Health District. I spent 13 years working in and directly with Miller, so it's very deep both to our centers and my heart in terms of the work. And it also builds on the work that Liz Harris started with Vanessa, Ben, and Joan as well. So just click.
It's just here.
Oh, just click it.
Yep, that one.
Okay.
Right? Just press.
Start.
Not working.
No.
One, two.
Oh yeah.
There you go.
Okay. So, like I said, it's a long history with our center. But firstly, I would like to acknowledge, obviously, my co-authors and the people that are involved from CPHCE, Margot, Catherine, Carla, my colleague at Tetra, Mark Harris, and Patrick also from Tetra with this work. So I'll be talking about where's Miller, for those of you that are not familiar, and why we're concentrating on Miller. Bit about the methodology of the survey that we've conducted, a snapshot of the results, and our next steps of what we're doing in terms of opportunities and working collaboration with the survey and the results. So Miller, for those that I don't know, is a small pocket, a suburb within the 2168 postcode of Liverpool local government area, 38 kilometers from the Sydney CBD. It's got a population of just over 3,000 people and 43% social housing. Now, in order to understand and reflect on the current findings, we have to pay a little attention about the background. And so Miller was part of Green Valley, and Green Valley, as some of you may know, was part of a social experiment done in the 1960s in New South Wales, where they wanted to get people out of the inner west, overcrowding of accommodations, and take them out to places like Green Valley. And the policy at the time was to create a breeding space for industrial expansion and provide the castle for his man and his family. So as you can see, bit of lawn, bit of open space compared to the inner west overcrowding flats. But 10 years long, in 1973, now the famous Peter Weir, film director, actually did a documentary on Green Valley, where he actually gave cameras to residents to document their lives. Because at the time, the media had in their headlines had Green Valley was a valley of darkness, Dodge Valley, Pram City. And 50 years on, in 2015, Tetra did another, at the end of that documentary of what happened to Green Valley, there was a Q&A session. And we replicated that in 2015. And people were saying the same issues that they were brought up in 1973, they had in 2015. They were said we were, obviously badly treated by the media. We were stigmatized. We were stigmatized. There were things like we had 2 in 5 had cars, 1 in 10 had a telephone. It was, even though it was within Liverpool local government area, it was geographically isolated in terms of public transport. And so we were just given a bad rap, and our voices weren't heard. Other people were speaking for us. Miller today continues to be one of the most disadvantaged suburbs, not only in the LGA, but in New South Wales. And as you can see from the ABS index, the social index of social disadvantage, it's number 701, where the average is 1,000. And as you can see, the darker the red, the more disadvantaged there is. Now, like I said, Tetra has a long history in with Miller and conducting the Miller Household Survey. And it started back in 1999 with Liz and the team itself. And actually created baseline data for a project called Wellbeing in the Valley, which later turned into the Hub Community Health Center, where I started my journey with Southwest City. So if it wasn't for that survey, I wouldn't have had the opportunity to start there. So from 2002 to 2010, the survey actually informed a major renewal project in the area called the 2168 project, which was funded by Department of Housing, Health, and the local council. And that was to strategically bring everybody together to actually fix some of the major issues in the area. And obviously with the current one that we did in 2022 to 23, we're informing the sector, or we're hoping to inform the sector. 13 years gap, so there's a lot of things that have changed. So with this current survey, it's funded by a number of partners, the local health district, primary community health, but also population health with My Time, and Liverpool Councils through the community donation program, and CPHC as well for the data collection. So the survey we conducted was a cross-sectional survey on a randomized sample of 600 homes between November 22 and 23. And this is what, based on historical methods in terms of previous surveys. We mainly use door knocking like previous surveys, but we took the advantage of dropping off and picking up surveys. And we also had a QR code. Given after COVID, we thought people were used to the QR code as well. So, and one of the things we did was with the 2010 one and with this one, we actually recruited residents and trained them up. We had a specific TAFE training program. So we've trained them up, we've given them employment, and that's our commitment to working in locational disadvantage and health equity. So they were with us with this round, we had 6 people, and by the time we finished the survey in July, we had 2 people, and that's because people, journey of life, people getting jobs, and the training helped them to move on as well. So we lost them, but it was also good outcome for them as well. So we got nearly 52 response rate, which is fantastic. And that's primarily also that was due to the fact that we employed local people who knew local networks. If they didn't, they learned about, people in the area. And people weren't talking to strangers as well. And also what we did was we actually went back 3 times, which followed the same procedures as 2010 if people went home. So we tried to make every effort to go back. With the languages, with the people that we recruited, we tried to get, the languages of reflected areas. So we had Vietnamese, Mandarin, Samoan. Unfortunately, we didn't have Arabic, so we had to exclude them from the surveys. So who did we talk to? So 62% were females, 65% were 45 and over. Residents were that we spoke to were born over more than 50%. 50% were born overseas, which was different to the 2010 one, was slightly up. 13% were indigenous. 58% were not in the labor force, so mainly on age pension or disability pension. 28% didn't have any qualifications, left school and didn't have any qualifications. And the majority of people that we spoke to were in social housing, with 30% owned or having a mortgage in their own homes, and 19% were rental, in private rental. And 59% of homes had household computer was computer access or internet access. So 83% of people completed a survey with an interviewer, and that's because people still liked face-to-face communication, dropping off and completing themselves didn't help, but people still liked that conversation, and in some cases, it was the only conversation for the day. So the major issues that came up were speeding traffic and drinking in public, which were the same top two issues in 2010. In 2010, speeding traffic was 60%, so it's still a lot higher, but in 2010. And in terms of these concerning issues, it was assault, burglary, and domestic violence, which was contrary to, if you listen to people's anecdotal stories, people particularly were saying that, there's fighting happening all the time. We saw in COVID, people staying at home, domestic violence went up. But it seems to be the case, people were saying it's so normalized. There was incidents where we were interviewing people, and a couple of doors down, people were fighting, but never blinked an eyelid. In terms of what divided the community, again, it was drug and alcohol, which was the same thing in 2010. Mental health was 36.6%, and generational differences as well. In terms of least divisive issues, it was religion, ethnic background, and the differences between old and new residents were similar results to the 2010 one. When we asked people, can most people be trusted? 60% said no. When we asked people, who would you feel like to turn to for help? And 77% said family and partners. And when we asked people, have you been involved in any decision-making processes? As you can see there, 94% said no. Mind you, this was conducted just after COVID. And so the area has always had a resident group, but they were aging. And then obviously with COVID, they were disbanded as well. And lack of computer access for some of them. When we asked people, do they feel you have the power to influence or change things in your area? 91% said no. And these were similar to the 2010 ones as well. And then we asked people, would you like to have the power to influence, change, what goes on in your area? And 73% said no. And that's because, people said we can't be trusted, nobody listens to us. We were marginalized by the media long time ago. We can't be trusted. Most people could make decisions on their own. 62% said, majority said they still felt at home. And in terms of has the area improved, people said, 40% said yes, overall it hasn't quickly improved. People said they were in relatively good health, with 13% saying that they were in excellent health. But in terms of physical and mental scoring, as you can see, were the same in 2010 for physical and mental health. For physical health, and mental health has certainly declined. So mental health is definitely an issue in the area. In terms of usage, people said they used medical services in the last, majority said they used medical services in the last 6 months. 79% said GPs, followed by hospital visits and specialists. Other services included, majority of services, the hub, which is the community health center, Centrelink, and others. And in terms of the reason why people weren't accessing services, waiting times, as you can see there, services not in area, transport, and cost were reflected there. But overall, people said they were quite satisfied with the services they received overall. So next steps, what we're doing 60 years on, the Green Valley experiment is still going on. And so hopefully our survey is to inform the planning of the sector and provide that information for services and stakeholders to empower them to use it for advocacy. So 2 ways quickly. One, Liverpool Council has a Miller Social Master Plan, which we're hoping to inform with the results, and then the local 2168 interagency as well. And that's a copy of our survey. Thank you.
Thanks, Andrew. I'm having trouble restraining myself from asking questions already, but we're going to save them. So for our next 2 presentations, we're shifting locations from southwest Sydney. We're moving inner west now to Waterloo, which is currently undergoing the biggest social housing redevelopment in Australia. So our next presentation is from Catherine Meikle. Kat joined the centre through a capstone placement during her undergraduate degree in 2021. I think Margot mentioned earlier on how we have a tendency to kind of find people and then hang on to them. Since then, she has continued on to contribute to various research projects while also supporting conveners who have been teaching. Kat has an interest in artificial intelligence, machine learning, and the visual communication of data using interactive dashboards. She's currently nearing the completion of her Master's in Health Data Science, and she's going to talk to us about the Waterloo Tenant Survey, which is really interesting in contrast to the Miller one. This is a new survey, a baseline survey. Over to you, Kat.
Okay, so today we'll be looking at the results from the 2023 Waterloo Tenant Survey, which focused on key areas of the Waterloo Human Services Action Plan aimed at improving the community. Locational disadvantage has a significant impact on individuals and communities, shaping their access to essential services, employment, and social opportunities. Where people live influences their exposure to crime, access to resources, and overall health outcomes, often reinforcing a cycle of disadvantage. Waterloo is a prime example of locational disadvantage within a major city. Although it is surrounded by more affluent neighbourhoods, Waterloo faces significant socio-economic challenges, with one of the largest concentrations of public housing in Australia. The Index of Relative Socio-Economic Advantage and Disadvantage reflects this disparity, ranking Waterloo among the most disadvantaged areas in Sydney. A closer look at key demographics shows that Waterloo's population is older, predominantly male, and largely composed of single-occupant households. Many residents rely on government payments such as the age pension, disability support payments, and job seeker payments as their primary source of income. The community is also highly diverse, with 39% of residents from culturally and linguistically diverse backgrounds. English, Cantonese, Mandarin, Russian, and Vietnamese are the main languages spoken, and 12% of residents identify as Aboriginal and/or Torres Strait Islander. In response to ongoing challenges and in preparation for major redevelopment, the Waterloo Human Services Collaborative Group was formed. This group unites stakeholders from government agencies, non-government organisations, academic institutions, and community groups to address the current and future needs of the community, particularly residents in public housing. The collaborative group uses a co-governance structure, focusing on engagement, planning, and coordinated responses to support residents. While many members had already been working together for years, the group was formally established in 2021. Through shared goals and ongoing community consultation, the collaborative group ensures that efforts are aligned to improve well-being and remain responsive to changing needs. These efforts are guided by the Waterloo Human Services Action Plan, which was developed by 2 coordination groups who reviewed input from agencies and tenants about human service issues in Waterloo and endorsed by the collaborative group at the end of 2021. The Waterloo Human Services Action Plan focuses on 6 key areas: improve safety, better health and wellbeing, enhance communication and community participation, improve customer service, better service integration, and addressing systemic issues. In 2023, the Centre for Primary Healthcare and Equity was commissioned to review both the collaborative and the action plan. While the plan was developed in consultation with the community, it was decided to conduct a more comprehensive community survey to capture a broader range of voices and to provide a baseline dataset. This survey was designed to further inform the action plan and serve as a tool for tracking changes in community attitudes and experiences over time. The survey targeted residents aged 18 years and over who had lived on the public housing estate for at least 6 months. The survey was developed in consultation with representatives from the Waterloo Action Plan Review Group and members of the collaborative group. It focused on measuring key areas that the action plan aims to address, such as safety, health and wellbeing, experience with government and community agencies, and community engagement. Where possible, questions were adapted from established surveys, including the ABS Social Services Survey, the Regional Wellbeing Survey, and the Australian Institute of Criminology's Community Safety Survey. The survey was promoted through multiple channels, including SMS invitations, posters placed in key locations, and QR-coded flyers distributed to mailboxes. A key strength of this approach was its focus on inclusivity. To ensure accessibility for non-English speakers, all promotional materials and the survey itself were translated into Chinese, Russian, and Vietnamese by Multicultural New South Wales. Additionally, events like Summer on the Green offered residents the opportunity to complete the survey with the help of community services, helping to capture a wider range of perspectives from the Waterloo community. A total of 320 Waterloo public housing tenants participated in the survey. While most respondents completed the survey in English, a portion completed it in Chinese, Russian, and Vietnamese. The majority of participants were male, aged between 55 to 74 years, and 17% identified as Aboriginal or Torres Strait Islander. Over 20% of respondents spoke a language other than English at home, with Mandarin and Russian being the most common. In terms of education, 30% reported completing Year 10 or below. Nearly 40% had lived in Waterloo public housing for over 10 years, reflecting a well-established community with deep roots in the area. When people feel unsafe, they tend to stay isolated, making it harder to build a strong community and worsening disadvantage. In Waterloo, while most residents reported feeling safe at home during the day, this sense of security significantly decreases when walking around the neighbourhood, especially at night. Nearly 60% of residents reported feeling unsafe after dark. Fear of crime in Waterloo is not just a matter of perception. It reflects the real experiences of many residents. More than half of the respondents reported experiencing a crime at or near the Waterloo public housing estate within the 6 months prior to completing the survey. This includes incidents such as burglary, theft, public harassment, and physical assault. Additionally, 65% of residents witnessed a crime during this period, with the majority observing someone being insulted or harassed in public. Even though reporting crime is essential to improving safety, only 29% of those affected reported it to relevant agencies like the police or housing estate services. Among those who did, nearly 60% were dissatisfied with the response time, and over half felt their concerns were not addressed promptly. Security remains a significant concern for Waterloo residents, with 65% of respondents agreeing that it is a major concern on the estate. Only 43% of residents felt that the police and other agencies are working effectively together to tackle crime and antisocial behaviour. The major issues identified were drug dealing, excessive alcohol use in public spaces, noisy and rowdy behaviour, as well as vandalism and property damage. These ongoing issues may contribute to a feeling of insecurity and distrust in the effectiveness of the response from local authorities. The survey revealed significant differences in self-reported health between Waterloo residents and the New South Wales average. Nearly half of respondents in Waterloo rated their health as fair or poor, compared to just 15% in New South Wales overall. This stark contrast highlights the ongoing health challenges in the community. In addition, over 50% of respondents reported having one or more physical health condition. 36% stated they had a mental health condition, and 27% reported living with a disability. Only 21% of respondents indicated they had no physical or mental health condition. Loneliness is an issue in Waterloo, with 28% of respondents stating that they often feel lonely and another 36% feeling lonely some of the time. The data reveals that younger residents are the most affected, with the highest percentage reporting that they often feel lonely. In contrast, 41% of those aged 75 and over reported never feeling lonely, highlighting an interesting difference in loneliness across age groups. Access to and experiences with services play a crucial role in the well-being of Waterloo residents. The survey explored interactions with health, aged care, and disability services alongside other government agencies. It revealed both positive experiences and challenges faced by residents when trying to access these services. Over 90% of respondents had visited a general practice in the past 6 months, with many also engaging with hospitals and community health services. Around 1 in 3 residents use aged care services or the NDIS. However, more than 25% of those who had contacted these services reported problems accessing them, with community health services seeing the most challenges. Satisfaction was generally higher for general practice, hospitals, and the NDIS. When looking at interactions with other government agencies, more than 3 in 4 respondents had accessed housing estate services and over 60% interacted with Centrelink. However, 45% of respondents reported problems with Centrelink and 40% had issues with housing estate services. While respondents expressed relatively high satisfaction with interpreting and translation services, as well as Centrelink, they were less satisfied with housing estate services and the police. The survey revealed that a significant number of residents have a strong connection to the Waterloo community. A majority of residents agree that they feel part of their community, and 57% believe that Waterloo is a great place to live. Additionally, over half of the respondents felt that by working together, they could influence decisions affecting public housing, demonstrating a sense of collective empowerment. However, while many residents feel connected, there is still room for improvement. For instance, 43% of respondents expressed concerns about their voices being heard and their views mattering, while another 43% agreed that, given the opportunity, they would move out of the neighbourhood. Around half of the respondents agreed that community information was easy to find and they were aware of available services and events. However, fewer than 40% of respondents who spoke a language other than English at home felt that translation services and information in their language were easy to access. Close to 50% of respondents indicated they knew how to seek help with unresolved issues or complaints. Despite some challenges, community engagement remained strong. Many respondents had attended community events or meetings, with a substantial number also participating in organised groups such as social clubs, sports teams, or community organisations. Additionally, 24% of respondents took an active role in providing or supporting community services, and 41% reported volunteering for an organisation or group. At the end of the survey, respondents were given the opportunity to provide any comments about how to improve government or non-government services in Waterloo. A total of 127 participants shared their thoughts, offering a variety of comments and suggestions. Key themes included the need for better safety measures, improved access to health services, more effective communication between service providers and the community, and better coordination of services. Many also highlighted issues with customer service and called for greater accountability from service providers, particularly in addressing ongoing problems like antisocial behaviour and building maintenance. The survey results highlight the significant challenges faced by the Waterloo community, particularly around issues like safety, access to services, and community engagement. However, through the Waterloo Human Services Action Plan, these challenges are being actively addressed. By focusing on improvements in safety, health, and access to services, the action plan aims to create a more supportive and equitable environment for all residents. Future surveys will help measure the plan's impact and ensure it continues to meet the community's evolving needs, fostering lasting positive change. For more information, you can visit the Waterloo New South Wales Human Services Collaborative website, where you can access the full survey report, a 4-page summary, and an infographic summary report. The website also offers details about the Waterloo Human Services Collaborative and the action plan, including key updates and reports. We'd like to thank everyone who participated in the survey and those who provided support to the participants during the survey. We'd also like to thank the Waterloo Human Services Review Group for their advice in developing the questionnaire and their report. Thank you.
Thanks so much, Kat. So now for our final presentation, we're staying in Waterloo. So this presentation is from Dr. Esther Aloon. Esther is the Health Equity Research Associate based at Hurdu in the Sydney Local Health District and within CPHCE. As an applied social researcher, she works with health services and communities to better understand the causes of inequities and to develop evidence of effective action. She's going to talk to us about her research into a new model of community-based peer education. Thanks, Esther.
Okay. I am too short for this. Let's just test if it works. Is my time already started? Oh dear, okay. So I also want to start actually by acknowledging that this is the work of a team, so the research team, because we've heard a lot about collaboration, and I think that's really important. So Fiona Hay and Kathy O'Callaghan at the back, who helped a lot with this research, and also that it was supported by the implementation team from the Sydney Local Health District, SLHD for short. And particularly, thank you, Erin, for letting me use some of your really nice infographic, and Lisa Parsi and Luann Blunden as well. Thank you. I also want to start again by acknowledging that we are on the land of the Bidjigal people, and that this work took place on the land of the Gadigal people, and also acknowledging Aboriginal Torres Strait Islander colleagues with us. To recap, just to know where we are, I think today we're talking about people, places, and stories, which are actually 3 pillars of Aboriginal connection to country. And I'm already going off script, but I was wondering if Aboriginal connection to country and heritage management is part of the livability index, or some of those indicators, which thank you very much for making that research publicly accessible. We have used it recently, all the data on the Australian Urban Observatory, very easily accessible, and also even to people who don't use a lot of data. So Aboriginal people were the first storytellers of this land, and so I thought I would also humbly follow their lead and start with telling you a bit of a story. And this is a story that if you work in public health, although not all public health tells that story, you've heard that story before. And it goes something like this. Once upon a time, in the land of public health, there were people who had lots of health issues. And they lived not in castles with the men and their family, but in towers like these. We call these people vulnerable. These vulnerable people had health issues that overlapped with social issues too. Or at least that's what we say when we really mean they were poor and often did not understand or follow our advice. And every day we saw this burden of ill health and disease in our health services, in our hospitals. And every day we also saw that these vulnerable people did not access the healthcare they needed when they should have. And we were pretty stuck. So this is one version of the story. But today, and in line with the theme of the forum and Billy's excellent presentation, I just want to tell the story slightly differently. And I think we can tell it a little bit differently. And so the other version of this story that, again, I'm recapping, is something like this. Once upon a time, there were many social, economic, and environmental problems. These were difficult, complex problems. They were wicked problems, difficult to grasp, seemingly insurmountable. Disadvantage was one of these problems. And every day, people living in disadvantage, like social housing residents, experience poverty, denial of rights, social exclusion, being prevented from accessing opportunities and resources that are fundamental to health. And every day, people were reminded of this, right? The fear of crime and insecurity, we've just heard about it. That means that friends won't visit you, cab drivers will ignore you, health workers will judge you. The feeling of absence and neglect, the kind of parks and amenities that we saw in your slides. So these circumstances, these structures, these systems, they bear down on you every day. They create everyday pressures. They debilitate, they grind you down. They make it hard to be and to feel healthy. This, I argue, is not vulnerability. This is the result of policy. But besides policy and advocacy, which I will return to, what can people in low-income communities do in the face of such sticky, persistent disadvantage? Well, I guess the topic of this talk is to share with you the example of what the people of Waterloo did. But just to be really clear, also, this is not a story of individual moral responsibility. This is a story of community. This is a story of collaboration and collective action in the face of all of this. So what happened in Waterloo? In Waterloo, which is inner city Sydney suburb, residents, in partnership with the Sydney Local Health District and the local community organisation, Counterpoint, decided to work together to do something about disadvantage and the consequences that it has on their health. To make it easier to live a healthier, more engaged and fulfilled life. That was their vision. And to do this, they decided to use their strengths, some of which we've heard about in the survey, and a peer education model, which I'm going to get into in a minute. My role was to be a social researcher and to try and understand and document how and why this is happening. So let's dig down into what this program is about, the Peer Educator program. It started in 2022, and so the program trains and supports community members in Waterloo to become peer educators who then deliver tailored health information to other people in the community. Peer educators also gather information about what works, what doesn't work in the area, and they organize targeted assistance to groups of tenants using supports and resources from the LHD, from Counterpoint and other agencies. So the goals of the program, you've got them on the slides. Primarily two things, so improving knowledge and pathways to health services, but also, and mostly, empowering residents and reducing the social isolation that we've heard about in the survey. How does it work concretely? So first, local residents identify topics that they want to know about. And I guess we can pick one example, which was understanding people living with mental health issues and knowing how to support them. What's the problem there? Well, on the one hand, you often have residents who don't know what's happening for their neighbors. They worry about them if they're not acting as usual, if they feel stressed. That's on the one hand. On the other hand, you have people who have mental illnesses, who may be worried how the community is going to respond to them, and they feel quite isolated. So with this in mind, I guess that was identified as a problem, the program coordinator for the Peer Educator program worked with the mental health services in the LHD to develop and deliver content to this group of peer educators in an extensive session. And then the peer educators also shared their knowledge, their lived experience during the session. And together they work in small groups to then work out what information is relevant and how they're going to deliver it to the community. So a multi-stage kind of process. They used very creative ways to do this in terms of like the outward-facing activities that people delivered. 25 different kinds of activities, reaching over 600 social housing residents so far, counting, in Waterloo, but also in Redfern, Glebe, Camperdown, Surrey Hills. To pick up on the example of the mental health issues, what happened with that was that peer educators organized a trivia night with it was actually quite fun. Prizes, questions, so a lot of the questions were around mental health, kind of debunking myth about mental health. And you had also a social worker that was there, a mental health specialist that was there, and they've done other activities, including barbecues and presentations on nutrition's diabetes, decluttering and cleaning up day to talk about hoarding and squalor, which are really stigmatized things. Other kinds of outreach that they did in conjunction with health workers. So really, really diverse stuff. And obviously, after the training that peer educators that you've got on the slides there, after the training that they receive, they feel more equipped to give this information to other people through kind of ad hoc means. So with this picture that I'm painting, you can see that this is not your typical kind of program and it's not your typical kind of story. So I just wanted to also clarify, where did this come from? It was genuinely co-designed from the start with a group of housing tenants at the center of it. So the idea was to strengthen the web of care so that people can meet their holistic needs. And to describe that best, the tenant said, what we want is a program that says you're not alone and you have the right support. To do this, you leverage strength. Okay, we've heard a lot about problems. Now we're talking about strength. So the strength being, people wanting to help each other, to help their neighbors, and also the really long kind of successful track record of the SLHD working with Counterpoint and other community organizations to do collaborative place-based work, to try and build on that. So always and already, the program was more than we're going to pass on information to people. The problem is just information deficit. No, the problem and the solution was around building individual and collective community capacity. To tackle this kind of disadvantage, I've mentioned that already, you need more than one person to do this. You need collaboration. You can't do this alone. So this is really also a story of partnership. And many people came together to make this happen. So the Waterloo Living Program Manager from the SLHD recruited 20 peer educators. 10 different services in the SLHD were involved. Counterpoint played a major part. The local council also came on board, other agencies, not-for-profit. Big team effort. Now, you may be starting to wonder, what kind of fairy tale is this? Where is the evidence? I know we want, hard evidence to convince policymakers to make things different. So does it work? Does this actually work? Where is the evidence? Yes, it works. And you don't have to believe me. You can just believe the research. We conducted a really detailed evaluation looking at the impacts of the program. So it had positive impacts, and I'm not going to detail all of it. We have a great report that you can read. But in terms of the impacts on the peers and the community, we saw active engagement in health increase. We saw improved knowledge. But also, importantly, feelings of confidence, motivation, empowerment. And actually, I think the peer educators, those are quotes that we collected during the research. They describe it better than I can. Some of the feedback that we also got was that residents who had never really gone to community activities started engaging in community activities and showed up. Because, why? Because it's a different kind of program, because they came to hear their peers. And to relate to their stories. And then they were referred on to services, or they contacted the case manager at Counterpoint. So it did have ripple effect and impact in this way. Importantly, we also looked at the impacts not just on the community, but also on the health system. And we got, there was positive signs that the health system was kind of recognizing the value of lived experience and trying to use this knowledge to better target the services and the delivery and the reach of services. I really appreciated what we heard earlier from Billy around, well, it's great that we have this evidence, but we also really need to understand, with complex stories is with what I'm telling, you need to understand how and why it's actually happening, how the program works. Because to demonstrate the value of these kinds of programs, you need evidence. Otherwise, again, it just becomes this story of like fuzzy intervention, that we don't really understand that well. And to counter the kind of deficit story that I told at the start, and also to do this well, because there's many ways to do this badly, I should say. You need to understand what is causing changes, what are the key mechanisms that create those outcomes? And to do that, we did a mixed method realist evaluation for our technical people to basically learn so we can inform what we do better. Extensive data collection, qualitative mostly, because that's what I do, and also some quantitative evidence. What did we find in a nutshell? How and why does this work? We identified mechanisms at 3 levels. The first one being having the right peers. And all I will say about this is that shared experience, so the fact that you share a social background, is necessary, but not sufficient to make a good peer educator. There are many other characteristics that we found. Second, you have to engage these peers in the right kind of program. Here, a lot to unpack, but basically having the right kind of facilitator was really important. Having a really broad remit for what the program is looking at. Investing in training, so not just, pamphlet and information dump, but promoting training that values equity, that values non-judgmental spaces, and a really supportive group dynamic, so people coming together and feeling like they can change things, and that they have valuable knowledge to share. And lastly, the third ingredient in our recipe was having a supportive environment, by which I meant the partnership that I've already talked about, from the Waterloo Collaborative, from the executive, from Counterpoint, having access to staff time and resources. All of this takes resources. I don't think we've heard that word that many. We've talked about policy and all those things, but resources are really important. And lastly, also being quite deliberate about the values of the program and making sure that everyone is on board with this. So you share power, strength, that it's strength-based and those kinds of things. So to sum up, almost done, this is not a fairy tale. It is backed by evidence. And, to make these kinds of program work, you need to engage people from the start, enable, empower people, and also feed that back to the health system. But I do want to conclude with coming back to my story of disadvantage from the start, because disadvantage refuses to go away, right? So if the same people in the same places, as we've seen, experience those intersecting disadvantage, that means that there is a pattern, and that reflects decisions that are made about who gets what, how, in what way, and that also means we can do something about it. The sort of things that we can do is, the kind of elephant in the room, which is about maintaining social housing in well-located areas. Waterloo is really well located. So, in the light of the redevelopment, that's an important point, but also advocating for more equitable allocation of resources, as well as these kinds of programs that